Hello, my name is student clinician Tyrone Bird. Um, I am here to show off some projections today, including the hand, the wrist, and the forearm. This is my 17 by 7 poster board, 17 by 17 poster board that I'll be simulating as a tethered DR panel or cassette. I have my markers here as well. We're going to start with some hand projections. I'm going to say that my left hand here is the affected hand. First projection is going to be PA hand. So we're going to have the patient seated, hand placed, fingers slightly spread. Put the marker down here, left marker. And this is a 40 SID. We're using a 10 by 12 cassette. Central ray is going to be perpendicular to the third metacarpal. It's going to be centered to the film. We're going to collimate down to reduce OID and make sure we get the proper structures in for projection. And what we're looking for are carpals, metacarpals, phalanges, interarticulation of the hand, and we're going to include the distal end of the radius and ulnar. We're going to instruct the patient to don't breathe, don't move, and we can place a shield on their lap to protect from radiation. So that's the PA hand projection. Now we're going to move over to the oblique hand projection. Have the patient rotate their hand to an angle on the knife edge here, ulnar side. We may have a sponge or a pillow here for them to rest their hand upon. And with the oblique hand, 40 SID cassette, again on a 10 by 12 cassette here, and the central ray is going to be perpendicular again to the third metacarpal phalangeal joint, again centered to the film. It's also normal for the central ray to kind of sit on the second metacarpal phalangeal joint in this particular case, or this particular projection. Anatomy here again is the carpals, metacarpals, phalanges, distal end of the radius and ulnar, and the inner articulations of the hand. Next is going to be the lateral hand. You're going to have the patient rotate the hand up, lateral, and here we're looking at 40 SID, 10 by 12 cassette. Central ray is going to be perpendicular to the metacarpal phalangeal joints. In this case though, with this particular projection, we're going to see structures of the carpals, metacarpals, phalanges, and distal end of the radius. And the ulnar are all going to be superimposed in this particular projection. The thumb is going to lay to the side. It's not going to be superimposed, but you'll see it on the projection. Again, we instruct the patient, don't breathe, don't move. We collimate down to reduce OID. With the patient seated, we can place lead shielding on their lap to protect from radiation. All right, we're going to move on to wrist views. So let's go ahead, and again, left hand is the affected hand. We're going to start out with the PA wrist. In this case, we're going to have the patient lay their hands flat, and we're going to have them roll their fingers into a fist, or at least roll the fingers underneath here. It's going to reduce the amount of space here and get the wrist to lay as flat as possible on the cassette here. So with the PA wrist, SID again is 40. We're using a 10 by 12 cassette. The image, or the central ray, I'm sorry, is perpendicular to the mid-carpal area. And what we're looking for here are the carpals, the distal end of the radius and ulna, the proximal end of the metacarpals. We're going to instruct the patient to don't breathe, don't move. we're going to collimate to reduce OID and lead shielding on the patient's lap as they're sitting close to protect them from the radiation. So the PA oblique wrist, I'm going to have the patient roll the hand up, kind of make sort of like the OK symbol here. And we typically have like a sponge or pillow for them to rest as well. And 40 SID on a 10 by 12 cassette with the central ray being perpendicular to enter at the distal radius. We're looking at carpals in this particular view as well. Ask the patient to don't breathe, don't move. Collimate again to reduce OID and include a shielding to reduce radiation. Next is the lateral oblique wrist view. Have the patient bring the hand flip over, but not completely supinate, kind of at an angle here. 40 SID, cassette 10 by 12. Central ray is going to be perpendicular to enter at the end of the distal radius. And in this particular view, we're looking at the piezoform specifically. Again, ask the patient, don't breathe, don't move. Reduce collimation to reduce OID, and include shielding to protect from radiation. Lateral wrist. We're going to have the patient rotate the hand laterally. Now in this case, the thumb can actually lay on the other fingers here and set it to the side. 40 SID, cassette 10 by 12. Central ray is going to be perpendicular to the wrist. Anatomy, we're looking at carpals, proximal ends of the metacarpals and the distal end of the radius and ulna. Again, ask the patient, don't breathe, don't move. Collimate to reduce OID and include shielding to protect the patient from radiation. We have a couple special views here, including wrist, ulnar flexion. We're going to have the patient seated and shielded to protect from radiation. SID is 40. Cassette we're using is an 8 by 10. The central ray is actually going to be perpendicular to the scaphoid. Something to note with this particular projection, it is also normal to use a 20-degree tube tilt toward the elbow in order to capture this projection. Anatomy here, obviously we're looking specifically for the scaphoid bone. Next is going to be the wrist carpal tunnel view. And in this particular projection, we're going to hyperextend the wrist back, either by having the patient use their other hand or some type of device that holds the fingers in this particular projection. Here we're also going to have a 20-degree support. The SID is 40. The cassette is on 8 by 10. Central ray is going to be 25 to 30 degrees toward the palm of the hand, which is going to be approximately 1 inch distal to the base of the fourth metacarpal. And in this particular view, we're going to look at carpal tunnels, again, carpal tunnel, piezoform, tricutrum, capitate, hamate, and the greater and lesser multangular. Next view is the AP Stetcher method. It's a view of the wrist. We're looking at the scaphoid specifically in this particular view. Now, there's 40 SID using an 8 by 10 cassette. Now, in this particular view, you're going to have a 20-degree support here, and you're going to lay the hand would be laid down there, and the central ray is going to be perpendicular to the scaphoid. All right. Next is going to be forearm. So we have two forearm views. First is going to be AP forearm. We're going to lay the hand or lay the arm flat on the surface here, supine position. Again, 40 SID, 10 by 12 cassette. Central ray is actually going to be midpoint on the film. And the anatomy we're looking at is the radius ulna, distal humerus, and proximal row of carpals. What we want is the humeral epicondyle to be parallel with the image receptor plane. Lateral forearm, it's going to be a little bit different. So we're going to have the patient shift over, shoulder, forearm's actually going to be parallel with the table. Left here marker, 40 SID, cassette 10 by 12. Central ray is going to be perpendicular to the midpoint of the film. And what we're looking at here is the radius ulna, distal humerus, proximal row of carpals. Going back, proper instructions for both the forearm views is going to be, or all the views in general is going to be, to ask the patient, don't breathe, don't move. We're going to reduce collimation or collimate to reduce OID. Make sure we have the proper structures in the projection, and provide shielding to protect from radiation. So those are our views. Hand views, wrist views, some special wrist views, as well as forearm views. And that concludes the video. Thank you.